Ladies and gentlemen, we'd like to call to order the Rutherford County Benefits and Insurance Committee meeting. And we have before you a copy of the minutes of the last meeting. That would be our first agenda item. Do we have a motion considering the minutes approval? Mr. Sellers, a motion. Do we have a second from Ms. Boney? All right. Was there any discussion, any corrections or additions? If there are no corrections or additions, then everyone in favor of that, please say aye. Aye. Any opposed? Okay, so that is unanimous. Now, Mrs. Stinson will proceed with the information regarding our financials.
Good afternoon. If you refer to Fund 264, we'll go over our medical plan results for the month of March. In the month of March, our per employee per month cost was at $733.13. That's compared to $697.74 for prior year. The year-to-date average is at $663.79 compared to a prior year-to-date average of $686.70. When you add in the Care Here results for the month of March, our current results are at $763.34. The month-to-date average for prior year was $730.22. We're still trending down currently at 5.1%. Our net OPEB obligation at the end of March stands at $38,780,650. Are there any questions about Fund 264? If you refer to Fund 266, this is our on-the-job injury program. Our year-to-date expenses have been $721,156.60. That represents 94% of prior year, which was at $770,546.08. We did have one settlement in the month of March, so you will see that the cost for a monthly basis was slightly elevated over what we typically see in a month expenses. Are there any questions on that particular report?
Does anyone have any questions on the financial report? A continuing good trend, is that correct?
Yes, sir, that is correct. No, sir.
Okay. We don't have to have a motion to approve that then. So then we'll move right along with the statistics on the workers' comp and OJI, and Mr. Good will give us an update on that.
Good afternoon. You should have the OSHA report there in front of you. In the month of March, we had a total of 24 injuries requiring medical attention. As you look at your report, you can see the breakout of the type of injuries that they were. Total for the year at this time is 73. Of that 73, 44 of them were recordable under OSHA. 18 of them had restricted days. 8 had lost days claims to them. And then there was 18 for all others. If you look at the next page, you'll see the graph, and you'll see that we have been trending the last 2 months a little bit higher. There's no real reason for that. I mean, it just seems to be kind of along the wave as on-the-job injuries happen, as you can see. Hopefully, as we start moving on a little bit more into the summer, that those will come back down. For a total of the 24 injury claims, the net dollars incurred were $30,090. The breakdown was for the county general, had a total of 14 claims, and you'll see that on 2 sheets. The database is breaking out one separate there. And the total incurred dollars for the county general was $16,320. The Board of Education had a total of 9 claims, and again, that's breaking one of them out there under a separate one behind this one. And it had a total incurred dollars of $12,450. And then the final result for the county was with the Highway Department, and they had a total incurred dollars of $1,320. Do you have any questions?
Okay, any questions There being no question, things must be doing well, and we appreciate that. Good report. Thank you. Now, we're going to have a wellness update from Ms. Kelly, and she'll tell us about that.
Hi, good afternoon. If you'd like to pull out your Smart Steps report, we could talk about March Wellness. We had a lunch and learn on stress reduction at the health department in March, and we had 40 people in attendance. We had a grocery shopping tour given by Care Here on the 22nd, and 6 people in attendance. Care Here also started their weight management program in March with 7 people, and diabetes and exercise class had 7 people. We had a lunch and learn at the correctional work facility for Big Brothers and Big Sisters with 13 people in attendance. Upcoming webinars for Teaching Tuesdays in May are nutrition FAQs, frequently asked questions, organic foods, surviving allergies, Care Here Way, and stress management. All of those are at various times. You can look on the flyers through email blasts or go online and register or see their scheduled times. Upcoming activities that we have for May: Body Image Movie Night is at the Teachers Center next Thursday from 5:30 to 7:30. There will be a light dinner provided there. Our next HRA clinic is an annual physical at Laverne Primary from 7 a.m. to 9 a.m. Healthy Cooking for Kids is at the health department, and it's just going to be a night where we bring families in and get kids involved in healthy meal preparation. And our financial wellness for May on the 21st, on Saturday, Ms. Haney is going to teach another coupon class. Anybody have any questions? Thank you.
And all of those program dates and times can be found on the HR Intranet calendar for county general employees and through Mr. James Evans' news and notes. So everyone can determine and find exactly when all of that's available. And I probably would suggest that all of us probably particularly should maybe eat our lunch and on that Care Here webinar for stress management on May the 23rd, 11 to 12. Okay. Now, the next thing you have before you is a document that simply documents, and we believe, hopefully, as clear and as simple of terminology as possibly can be done. There's nothing new here. It's a document that several people have contributed to, including a review by our legal staff, in that we want to be sure we've said this exactly like we've approved and over the past, well, substantial length of time. But in any event, here's a document that we believe is going to really put in place. It will be something that will be in our plan document, I believe, that clearly identifies something for those that come after us to at least understand what we have done. So I would suggest that if you read that carefully, and we hope there's no confusion left here. We hope we've answered the questions, but if by chance you were to find something that you think needs further review, I would appreciate if you let Ms. Stinson know. Anything else on that, Ms. Stinson?
No, sir. We would ask that this be the document that is referred to at any point that retirement benefits and the eligibility criteria and the rates are discussed, and that we no longer refer to the GASB documents that were previously developed.
So this is the document that's the standing document that we will use for our, I might say, the clarification of any issues that are forthcoming. Okay. Next, I have something called LTD, long-term disability contract.
Yes, sir.
Okay, so you're handling that, Ms. Stinson?
Yes, sir, I am. The long-term disability contract we currently have with Hartford expires at the end of the year. It's my recommendation that we put our long-term disability out to bid so that we can achieve the most desirable rates for the county. And I wanted to present that to the Insurance Committee for consideration.
Okay, say that again, please.
Our long-term disability contract expires at the end of the year, and I'm making the recommendation that we put that out to bid so that we can achieve the most desirable rates.
All right, so she would like to revisit that and put that back out for bids again on this long-term disability. Is there anyone that wishes to address that, discuss that, or make a motion that we do just that?
Motion to approve doing the LTD contract for out for bid.
Okay, do we have a second? Ms. Harvey, any discussion? All right, then all of you in favor of that, please say aye. 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 Any opposed? All right, thank you very much. Now we'll get into an issue here that will take us a little bit more time, I believe, in that we took requests for bids and proposals on the on-site clinic services that we have in place, and Ms. Stinson will direct us through a discussion of how this review of those proposals that we received have taken. So, and through the course of this, since this needs to comply with our Purchasing Private Act that we have, I will interject at several points here, a few points here, motions that will clearly let this committee here have full review and ability to approve what some of the decisions or some of the recommendations that's going to come forth from a smaller subset of this group as we enter this discussion. So we're going to turn it over to Ms. Stinson, and we'll work through this together.
There are 3 documents that you'll need to refer through our discussion today. One is the color-coded document, which is the on-site clinic comparison. The other is labeled the Rutherford County On-Site Clinic RFP, and the last is the satisfaction survey. On January 24th, we released a bid for our on-site medical clinics, and on March the 15th, the bids were due by 4 p.m. of that day. The bids that complied with the guidelines that were received and opened by the purchasing committee was for Concentra, Cigna, HealthStat, and Take Care. The value of the contract being proposed by each company, with the exception of Concentra, was read during the purchasing committee meeting. The proposal by Concentra required additional review, as an aggregated financial sheet was not provided with them as part of their bid. Upon review of the RFP, it was determined that incomplete financials had been presented by Concentra. There was missing components that would enable us to make a true comparison of their bid, both to our current cost and to the cost of the other bids that had been received. The following categories were initially used to review the 4 bids, and those were the financial proposal I just referenced, the services that were available, the technology that was used by the vendor, the accessibility, the interface with our employee population and their dependents, and the vendor integration component. Based on the lack of the financial information by Concentra, they were not selected as a semi-finalist, but the remaining 3 were, which resulted in HealthStat, Cigna, and Take Care being viewed as a semi-finalist for the RFP bid process.
So this is our first little pause in this discussion. So what I want this group is to ask her enough questions, if you choose to be sure that the subcommittee's decision not to include Concentra is appropriate with the whole body here. So what we really would like to do is have a motion to agree with the findings of the subcommittee to eliminate Concentra because they provided incomplete and information from the financial viewpoint. Therefore, a discussion or a review of them would not have been appropriate. So I first just want to, the little first sifting process, I want you to think about, if you will, agreeing with their decision to eliminate them from the further discussion, and then we'll go forward. Mr. Hall, you're making a motion to concur with the findings of the subcommittee not to go forward with Concentra's proposal based on the inability of and the lack of their providing of the proper financial information. Do we have someone that would second that motion? Ms. Barnes. Now, is there any other discussion on that? Anyone want to ask any detailed questions about it? Okay, that being the case, and all in favor of that, please say aye. Any opposed? All right, thank you. Continue on, Ms. Stinson.
There are 3 semi-finalists that we requested present to a subcommittee. That subcommittee consisted of Lisa Nolan, the Finance Director, Sonia Stevenson, the HR Director, Joe Russell, Chief Deputy of Administration, Mary Hickerson, the Highway Administration, and Paula Barnes, Assistant Superintendent of HR and Student Services for the Board of Education. I was also present during the interviews as I facilitated the meetings. We had these presentations over a 2-day period, which occurred on April the 11th and 12th, and the subcommittee reconvened on the 14th to discuss the interviews, the information that had been obtained, and the overall performance of the vendors. Following the discussion, based on the factors that were previously given to you, used for evaluation, it was decided that Cigna and Take Care be presented to the Insurance Committee for consideration. HealthStat, once we had an opportunity to interview them, their costs exceeded what our 2010 calendar year spend rate was, and in addition, they had a lack of local presence, which we felt would impact our ability to properly manage that relationship. If you will refer to the clinic comparison information, which is the color-coded sheet, I will walk you through that so that you can understand how this information is being presented. The startup cost, as listed, represents the cost to actually go in and do a takeover of the clinics. Each vendor gave a complete cost whenever they did the startup cost, because although we did clinic walkthroughs and allowed them an opportunity to speak with Care Here and ask questions, they haven't had an opportunity to actually audit those clinics and to see what all will remain should a different vendor be selected for the clinics, and to do a complete evaluation. Since it is a bid process, they presented the total amount that they would project as if they were building it from the ground up within an existing building structure. Both companies have indicated to us that the costs reflected are expected to decrease once they complete the audit. The program cost, which you'll see under the annual cost, includes the management fee and the expenses related to the clinics not defined elsewhere on this spreadsheet. The supplies and labs represents the clinic supplies and the lab costs associated with both the primary care services and the HRAs, which are the health risk assessments. The personnel costs, that's our labor costs for the clinic staff. Cigna, as you will hear today, if approved, is proposing 9 full-time employees. Take Care is proposing 11 full-time employees. And currently, just as a point of reference, we have 5 full-time employees and 9 part-time or as-needed PRN clinical staff assigned to our clinics. There is one piece of information I would like to provide. As part of our review, we wanted to evaluate not only where do we want to be in the next year, but where do we want to be in the future in terms of our clinics. And so there were a couple of important points that we addressed with the vendors. One of those would be to allow the providers to remain, should we ever make the decision as the county to replace the management company that existed for whatever the reason may be. Under our current arrangement, there is language in the contract that prohibits us, should we replace the current on-site medical provider, from retaining those clinicians that treat inside of the clinic. And it will create a disruption with our employees. So we want to safeguard the county against future incidences like that. So we have had those discussions and confirmations that that would not occur in the future under any other contract. The other difference is the providers will be solely dedicated to Rutherford County. Currently, physicians that practice in our clinics also may have outside private practices, and that would no longer be a scenario. Any physician would be full-time with the county, and their primary purpose would be to serve and take care of the employees and their spouses, dependents that use the clinics. And we think that is an important factor in both cost control and continuum of care, so we wanted to address that in the review as well. If you refer to the pharmacy line, the prepackaged medication costs are built into the overall cost. Cigna has built in $10,000 for pharmacy, and Take Care has built in $66,847. Now, compared to our 2010 cost, both of those numbers are considerably less. Just as information, from 2008 through 2010, so for that period of time, there was over a 130% increase in the pharmacy costs in our clinics. But when you look at the satisfaction survey, it continues to be one of the things that our employees complain about, that there's not an availability of medications when they go to a particular clinic. Now, the health department is an exception to that because they do not staff medication at that clinic because it is not a standing clinic solely for the purpose of Rutherford County employees. So we need to just be aware that there is this pharmacy built in and that it is less, and it's important that there are measures in place as we move forward that allows the ongoing evaluation of the pharmacy and allows us to better understand where our costs are that pertains to the pharmacy expenses. If you look at the information technology, the costs included on those lines are costs such as the licensing of employees. There is licensing of equipment, their equipment needs, the reporting that they will provide to us, the electronic medical records, and expected vendor data integration costs are also included in the IT cost. The HRA cost, currently our arrangement with Cigna allows for a health risk assessment that is available online. We don't currently promote the use of that HRA as much as we do the clinic HRA that we use through the current vendor. Cigna On-Site Medical has proposed to us under their arrangement to continue using that on-site, using that HRA that is currently available to us, so you won't see a cost reflected there for them. But as you're doing your evaluation, you need to also factor in that should we ever move from Cigna On-Site Medical, then we would incur additional costs related to the HRAs because there is a current benefit that would exist should we choose to use Cigna On-Site Medical. But if we ever moved from their admin, then we would begin to see some costs on the clinic side that wouldn't exist during the time that we are both on the medical administration and the clinic side of it. Take Care did not originally provide us the pricing of the HRAs, but there's additional costs listed on the spreadsheet, and the costs for those have been included in their overall projected annual cost of $1.7 million. In counter processing, one of the important pieces for us is to be able to capture clinic utilization inside our medical claims experience. Encounter processing is whenever there is an electronic medical record process in place, and they were charged per clinic incident that they report into the medical administrator. Sometimes those costs are just included in the IT costs. Sometimes they're reported separately. And as you'll see, one company did report it separately, whereas the other has it built in. And of course, it's built in currently because on Cigna, they're also our medical admin. But that is another cost that we would need to consider that could be a charge if we were ever to move from Cigna Medical and we had them as our on-site medical. The proposed cost as reflected, that is the amount of the original bid that was provided to us on the bid due date. Once we interviewed with the different entities and we identified other costs based on the needs of the county and available services from the vendor, we reflected that in the additional costs not included. So if you'll look at the Cigna line, you will see that their additional cost is $27,252. That is based on the expectation of additional staffing, based on the needs that we defined, and the expected lab cost. The other expenses that I've referenced earlier are not reflected in that number, but they need to be considered during your evaluation. Wellness is another one of those aspects that would be built in on the medical administration side with Cigna, whereas it is already reflected in the cost for the Take Care proposal. Just to give you a baseline, currently on our wellness program, we pay $2.75 per employee per month for cardiac and diabetic programs with Cigna. So that's roughly $140,000 a year that we could use just as a base if we were to pull out wellness and have to start paying for it separately. On the Take Care, you will see that their additional cost came in at $213,805, and that again is additional staffing costs identified through our discussion and their wellness and population health services. The annual cost overall, the annual cost for Cigna came in at $1,491,462, And the annual cost, and both of these exclude startup, for Take Care came in at $1,753,518. Our clinic cost for 2010 was $1,789,766. So through our discussions, as previously said, it was decided that Take Care and Cigna would be the two finalists based on the financial and the local representation.
Okay, again, we're at the point that we would like for you to ask enough questions for you to be comfortable that their selection of Take Care and Cigna as the two finalists in the elimination of HealthStat from the finalist category. Would you, again, I think maybe Mrs. Stinson, we can see that their costs are a little bit more than either one of the other two. Is there any other significant items that brought you to this conclusion?
Well, we compared HealthStat to the others. As I mentioned, the cost and the local representation. There was some other additional costs associated with them that we were uncomfortable with. So as an example, and this really goes back to the local representation, having someone available at our monthly meetings was going to incur air charges, hotel charges, and travel charges on a monthly basis for the county. So when we dealt in some of those finer details like that, we felt like that maybe it would be more of a cumbersome relationship and also a more costly relationship.
Okay, so you've heard her presentation. What we need here is a confirmation, a concurrence with the findings of the review subcommittee that the two finalists should be Take Care and Cigna. Do we have a motion? Ms. Hickerson, do we have a second? Okay, Ms. Barnes and Mr. Hall either. All right, now, is there a discussion? Ms. Stevenson.
I just have two questions for clarification. So it would be safe to say, I think, based on your explanation, that under the Cigna side where it shows the percentage of change from current to 32% savings, if that's what I'm understanding, that should we have a different medical provider, that the savings would not necessarily be 32% because the items that are to be determined would be items that we would be charged with by another carrier.
That's correct. Those are costs that would currently be built into our medical administration arrangement, but should we ever move from Cigna as our medical administrator, then we would start to incur additional costs. And one in particular I can give you as an example, the data integration is key to our ability to effectively manage our clinics, understand where our true medical costs are, and to understand the needs of our employees in terms of the treatment type, et cetera. Whenever we were interviewing HealthStat, they needed to receive a monthly file from Cigna, which is basically a claims file of the prior month's experience, so that they could go in and stratify that information and look for high risk and things of that nature. Cigna was going to charge $750 a month to provide that claims file to HealthStat. And so anyway, on the other side of it, HealthStat was also going to charge us $200 a month to get that information and to stratify it for us. So there's a lot of detailed base costs like that we really don't know would exist right now, if they would charge us for them or not charge, and what that amount may be, but they can be substantial costs.
My other question was under Take Care, the $213,000, where it's talking about the HRA information is not included. Does that $213,000 include? Is that where it's included at that point?
Yes, it is. It's included there.
Okay, the motion now centers on concurring with the naming of both Take Care and Cigna as the finalist. Any other discussion? Ms. Hickerson.
Just along the line of the whole medical thing, just from being a part of it, for information for everybody, these clinics start September 1st. And if I'm not mistaken, next year we will let our health insurance out for bid. Will a new carrier possibly take over come July of 12? So just for information for everybody, that we could possibly, whichever way we go here, we'll have a new on-site clinic from September of this year, and then we'll let out for bids our medical insurance, and that's what we're talking, if we lose Cigna as our medical TPA provider for our health insurance, these additional costs to be determined kick in July 1 of 2012. So even the savings difference, you wouldn't even have a complete year of savings if we went with Cigna and was able to keep everything in one bucket and then have to switch out because of medical bills. So that was just something that come up during our conversation in the subcommittee.
That is correct. Our current contract with Cigna expires June the 30th of 2011. So we will be hearing a recommendation to put our medical administrator out to bid for 7/1/2012 effective date.
Okay, is there any more discussion on this motion to concur with the findings of the subcommittee? All right, all of you in favor of that, then please say aye. Aye. Any opposed? Okay, thank you. Now then, Mrs. Stinson, we're down to the point whereby we're going to let Cigna and Take Care make their presentations, and would you describe that and coordinate that? Ms. Harvey, excuse me.
I'm sorry, thank you. I have a question about what you said back on that page about the personnel costs. You said that you were going to be reviewing the contract about not being able to keep, right now we have it in the contract that we're not able to keep personnel.
Correct.
And in the future, we want to do that because of the change. So whoever we select, will they be able to keep the same personnel as we're writing it in, or not?
The clinicians and the staff today, so the doctors that we've been accustomed to seeing, the nurse practitioners, et cetera, we will no longer have access to beginning 9/1 of this year, should we choose Take Care or Cigna. Now, as we typically go out to bid every 3 years, if we replace our current management vendor and 3 years from now decide to replace that vendor, then the arrangement would be such that we could retain the medical staff that treat at the clinics.
So as of right now, we cannot do that.
That's correct.
If you will tell me again on the pharmacy,
Mm-hmm.
you said that both of those items are going to be cut as far as expenses. Is that correct? Did I understand that correct?
Right. They have both proposed costs below our current cost that we are incurring.
So what we're saying is that the pharmacy that we have available now will be cut.
No, what that means is that the cost associated to the pharmacy in the clinics is expected to cost less. And realistically, pharmacy is one of those variables that, depending on the type of conditions being presented at the clinics, that should be your driving factor for your pharmacy cost. If anything, what that reflects to us is probably one of two things. The cost that they pay for the actual pharmacy that they expect to stock the clinics with, and the other is it also speaks to their prescribing patterns. And then what we would do is, as we watch and monitor the activity in the clinics, they would come back once they see, because you will hear from both of them, that they have performance guarantees about, obtaining the budget. If they see that the cost for pharmacy is going to exceed the overall cost for the program, then they will have to come back and provide cost justification. I mean, honestly, until I started looking at this process and looking at the numbers, I suspect that no one in this room realized that from the time that we did our bid back in 2008, when pharmacy costs ended in 2007 at $86,000 and something odd dollars, that at the end of 2009, we had $190,000 plus costs purely related to pharmacy in our clinics. So we need better reporting. We need better information on utilization so that we can understand what our true costs are and our needs are inside of our clinics.
Ms. Hickerson.
To speak on the note for the pharmacy, to know the cost, the less, is both of these companies will be presenting and have guaranteed they can track, which we do not have now, is my understanding. They can better track the usage and the drugs, and then pharmacy is not, if I remember from the meetings, pharmacy is not just the medicine, it's the Band-Aids and the et cetera. Is that correct?
Well, they had originally talked what they had referred to as over-the-counter, but there is a small percentage of that cost, but most of those items, like the vials that you use for labs and things like that, are actually built into the supplies cost.
Okay, but just to let everybody know is that either one of these companies, we have a better tracking system of what comes in and goes out of the clinic that right now we do not have.
Yes, they both indicate there is a reconciliation process there.
So following that, if we see that, for example, diabetes supplies, that there are several that are using that facility for diabetes and checkup and those kind of things, then there's a possibility that some diabetes supplies would be available at the pharmacy once they track that.
Yeah, and it could be that they're available initially as well. I think the point that I was making is that as we look at the utilization in the clinics, then it's fiscally responsible for us to do an evaluation and say, we can obtain these supplies at the clinics, and there is enough demand that justifies us stocking the clinic with these supplies, and we'll go down that path. I think what we're being most guarded against is to have inflation in our cost that we can't readily justify due to the absence of utilization information available at our fingertips. And I think that was really the aspect and the premise on which we did our review.
Mr. Hall?
I just wanted to, this is kind of, I mean, maybe to Mary or something, whenever you were looking at it, if you look at the supplies and the lab costs, Cigna's is half as much about as Take Care. And so you were talking about it are like the Band-Aids and stuff like that. Is one of those considered part of that in there, or is the other one considered in part of pharmacy, to where it'll come back later, or is that not? It doesn't have anything to do with it.
They all group, for lack of a better word, a little differently. So there, to be able to do a line itemization, it's not really proposed that way. What we do during the evaluation process is to make sure that all the costs are built in somewhere. And just like with the pharmacy cost, knowing what the expected expenses are, I had to separately request that to have that extracted out of the aggregated information that they had given in theirs. So eventually what we're looking at is the bottom line, to run things as we are accustomed to. What is our bottom line cost associated with this? Right, either one would be at least 5% less than what we had in 2010.
Ms. Stevenson?
And I think what you're speaking to, Ms. Harvey, is one of the things that we were looking at on the subcommittee when we noticed the difference in the pharmacy as well, and we asked some of the questions you're asking. And I think what it gets down to is when we looked at what we were currently paying for pharmacy and what our satisfaction report was saying, where the people were saying, the employees were saying, we're not getting the pharmacy items that we need, and we were looking at our cost and then looked at the difference, then that's when we were saying now we can have the ability to look at to see what is going out of each individual clinic as opposed as to the whole. And these individuals, their ability to purchase the meds would impact the cost that we were being charged, right?
Yes.
Okay.
Okay, then. Are we ready then for the presentations?
Right. What we will ask is representatives of both Cigna and Take Care will have 15 minutes to address the committee, and it will be followed by a period of question and answers from the insurance committee. We would ask that you all remember some of the points that we used during our evaluation and your evaluation as well. The financial aspect of it, the services that are being offered, the technology that's being used by the vendor, what is the accessibility that the member will have to the clinical staff, how do they interface with our employees and their dependents, and then what type of information will we have from a reporting perspective. After we go through the presentations, I'll be happy to share with you the findings from the subcommittee and address any other questions that you may have at that time. So we'll first start with the presentation by Cigna. So Ms. Dodd, if you could ask them to come in. This is Cigna. This is Cigna. Mm-hmm. Yes. We'd ask that the individual doing the presentation for Cigna please address the podium, please. They all bring in their SWAT team.
So you may come forward and whoever's the lead person can introduce the rest of your team and speak to this group and say what you'd like to say to them.
Thank you for having us today. We're representing Cigna On-Site Medical Group. With myself, I have Michael Slice, who's the Vice President of Operations for Cigna On-Site, Dr. Ed Schwartz, Chief Medical Officer for Cigna On-Site, Peter Gotti, Vice President of Business Development, and myself, Mitchell Wiseman, who's the Business Development Lead for the Southeast. We're going to hand out the presentations. Okay.
Do you have an extra? Yes, we do. No, we have an extra one here. Thank you.
You ready? Yes, sir.
Again, my name is Mike Slice, and I'm responsible for the operations for Cigna On-Site. And because we have limited time here, what I want to do is if you can turn to page 3, which is the financials that we have proposed in the RFP process. What I want to do is to give you a high-level review of the financials and where the numbers are coming from so that you'll have a better understanding of the proposed cost for the clinics. So if you look at the numbers, the very top number, the 11,600, that's referred to as potential participants in the clinics. The reason that that is important in this document is it's the driver for a lot of your associated costs. Because every time you have a visit within a clinic, there's cost incurred to do the visit, so it's going to drive some of your operational metrics. So the assumption is, if you look at the next line, it's assuming that 30% of the activities that are usually occur by an individual can be captured in the on-site clinic activity. That's where the 30% comes from. Typically, the number that is used in these calculations is an individual can generate anywhere from 2 to 2.5 types of medical visits that can occur either at a doctor's office, specialist, urgent care, etc. So this is saying of those 11,600 individuals that have access to these clinics that will utilize on an annual basis 2.5, these clinics have the potential to capture 30% of that business. As you look, as with all healthcare delivery, your biggest cost is going to be associated with your labor. because at the end of the day, that's your most expensive commodity in healthcare delivery. And as you go through that, what's being proposed here is that of those 4 clinics, there's going to be 1 physician, and all of these are full-time, meaning 40 hours a week individuals. You'll be looking at 1 physician clinic. 3 of the clinics will be staffed with a nurse practitioner mid-level. Each of the 4 clinics will also be supported with a medical assistant. That is the individual that may process, take the front office, and then support the clinician when they take you back into the exam rooms and process a number of the paper. Also, because of the complexity of the operations, we've added back in an operations manager to provide some of the business oversight for the clinics that are operating there, so that the clinicians can really practice on healthcare delivery and wellness as opposed to the business side of it. So under that, you'll see there are 9 FTEs associated with the proposal. The big dollar item is labeled as salary and benefits. And so that is the compensation that is going to be required to bring on this level of individuals, and with the associated benefits to support them. And again, the associated benefits, these will be Cigna employees, or the Cigna benefit package is reflected into those numbers. Under that, you'll start to see some of the large categories of items that are associated with running a healthcare facility. The first one that you'll look at is supplies. And typically in that number, you're going to see 3 components. That's going to be around what we would consider medical supplies, those that are associated truly to deliver the care per visit. There will be non-medical, that's going to be the papers and things that aren't there. The big one in that number is going to be around pharmaceutics, because this assumption is having the clinics have the ability to administer medication, and also reflected in that number is an assumption that I think it's 25% of the participants in these clinics will also receive their flu shots and things there. So that cost is already baked into that. The G&A really references your general and administrative expenses and what it takes to run a clinic. So with that, you would be looking at categories such as marketing, maybe some communication, maybe some continuing education dollars for your individuals, support dollars, which would be administrative support, travel associated with that, some of the insurances liability, and then clearly you're going to have some malpractice reflected in these numbers, for the providers, because you are doing healthcare delivery. The other gets into system expenses. System expenses is really around the automation component of doing healthcare delivery. In other words, these have to be computerized. We have to use electronic health records for standardization. It gives us the ability to do QA checks, and with that there are associated costs, and those costs are reflected from really the pipes and lines that we have to use to do that, the registration and the cost for the product itself, and then just the ongoing costs that may be associated with some of the database management when it comes to the medical. All of those total up, and the next line that you'll see is a line that's called management fee. And management fee is really where the cost and a lot of the profit resides for us in doing this. And that is a calculated number. And that number is a percentage of the total payroll cost. And total payroll would be the combination of the salary as well as the benefit package. And so that drives a percentage, which is the management fee that's associated. So as you can see going forward, as you elect to grow the size of your facilities, there's the potential for the management fee to go up, or if you elect to downsize, for the management fee to go down. So it's a direct proportion attached to the staffing for the clinics. And so you then have a total fee. The last one that you really need to look at is the implementation, and that's the cost of getting these clinics up. In this case, I think it's the transitional cost. You'll see a number that's reflected there at $215. That $215 is making the assumption that we have to go in, it's gray walls, and we have to replicate all the medical equipment, all of the furniture, all of the supplies, in addition to bringing in all of the computers, getting the new registration fees. I've been told that this is much more of a transition. So if you operate under the assumption that we just go in and we have to be focused really on the computers, and bringing in the hardware, the software, and the EHR, that you would see that number drop dramatically. I think if you're looking at reusing what's already there, that number is closer to 90, 95,000 versus the 215.
Again, thank you for your time today. My name is Dr. Ed Schwartz. I'm the Chief Medical Officer for Cigna Onsite Health. And really, before we get into the question and answer period of this morning, or this afternoon actually, I'm on Phoenix time, you'll have to forgive me for that. Really want to talk about why Cigna, because I think in the end, that's really what the balance has to come out. No matter what organization you go with, all the organizations are going to be delivering healthcare and doing a good job. Really, where our passion comes with the delivery of healthcare for yourselves, your employees, it's really recognition of the fact that we've got to do things different. And what do I mean by that? I think we've all experienced currently that in the healthcare system, it's become very transactional. When people see their providers, whether it's a nurse practitioner or physician, generally it's 5, 10, 15-minute visit, but it's really focused on that illness component. It's really not looking at how do we start preventing continued medical expenditure, quite frankly, and how do we keep people healthy? And that's really where our passion comes in, and where our model comes in. Our focus is to help people, number one, when they have an illness, they have a problem, to be able to obviously provide good quality care. But we want to go a step further, and we do that. We really approach people holistically to understand what are their risks, and what do I mean by that? Really addressing things such as, what are you putting in your mouth? How much are you eating? Are you exercising? What's your stress level like? Are you sleeping? Do you smoke? These are all easy things to say, but we all know that they're very challenging for people. So it's then partnering with those individuals to set up individual plans to help them over those barriers, because we know if we focus in those areas, 75 to 80%, and it's been proven time and time again, 75 to 80% of chronic illness is preventable. But on top of it, it's also reversible. And I will tell you, my background, I'm a family practitioner. And I still see patients. And what's amazing to me is the number of people that will take a pill, and now their numbers look normal. And they'll say, yeah, we'll be taking care of them. What disease did you have? I don't have any problems. Well, why are you taking this medicine? Well, I used to have high blood pressure, but I take the pill and my numbers are great now. I don't have high blood pressure anymore. So it's working with people to realize that just because you take something, again, how do we get people healthy and prevent? Now, the other thing that's very, very important, I'm sure many of you have heard of the term of the medical home. A medical home to me means going back to the way medicine was delivered before, where your physician took responsibility working with individuals and partnering to say, I'm responsible for keeping you healthy. So within this model, one of the things that's very important is recognizing by having a physician and the nurse practitioners, we know that nowadays many, many, many employees do not choose a primary care physician. Because as the gatekeeper models, went by the wayside probably about 5, 6, 7 years ago. I lose track of time as it seems to keep going quicker and quicker. All of a sudden we ran into a situation where people now don't have any doctor standing up and saying, I'm responsible for taking care of that person's health. I'm responsible for looking at them from holistically, knowing what this specialist is doing, knowing what this specialist is doing. So one of the things in this model, and by having that physician, is now that for those people who don't have a physician, and they choose that they want these 5 clinics, they want within this clinic setting, these providers to be their doctor. So the physician with the support of the nurse practitioners, the MA, we now will become their medical home. We will be responsible for taking care of their chronic conditions. We'll be responsible for knowing, again, what are all the specialists doing? I wish I could bring you guys into my world, because if I had $1 for every time I saw a cardiologist say that it's the respiratory system causing the problem and the pulmonologist standing right next to him saying it's the cardiac problem, nobody's looking at the whole person. So again, very important to recognize the medical home concept and how important that is. The other thing that's quite important to us is recognizing the relationship. So when we staff a clinic, it's not just the degree that gets us to hire somebody. And it's not just the fact that that person's can do quality care. We have to have the next layer of that. And what I call this is the it factor. So it's having those providers, nurse practitioners, physician, and even the front desk people, that when somebody starts talking to them, they're able to put that person at comfort, build that relationship. Because the other thing that's very important is we look at full integration. So let me explain what that means to us and what we will deliver to you. You spend a lot of money purchasing lots of services for your employees. So disease management, coaching, all sorts of programs that you also may bring to your sites that have nothing to do with the insurer, have nothing to do with, it could be Weight Watchers on site. Any program from now until the end that you determine you want for your employees, we actually train our employees about the existence of all those programs. Because what you find is most people, if you think about it, they have no idea what their medical benefits are. Until when do they find out? When all of a sudden they're sick. And then they're trying to figure out. So when we start looking at some of these other programs that help keep people healthy, help keep if they have a condition, keep it under control, they don't know about them. What we do is we train our employees and build referral segments within our electronic health record so that, again, we're identifying conditions early. We're partnering with people. So if I ask a patient, I will tell you right now, if I say, I really would like you to be involved in this program, this is why, I want you back in a couple weeks, I want to see how you're doing, the engagement goes way up and we see incredible results. So our whole thing is to be, again, integrate everything. The fact that you have Cigna insurance gives us the ability to also have additional data on people. Many, many people have no clue what medication they're on other than it's a blue pill. And they want us to remember, I'm on that blue pill, and we're going, have no idea. Or they don't even know what their diseases are. Again, unfortunately in medicine, I think it makes us feel smarter. We use lots of big fancy words, and people don't always remember what those words are. By being part of Cigna, we have something called, we have the integrated viewer. So I can actually, our clinicians in the exam room with your employees can see what their diagnoses are, can see what medications they're on, which is huge. Can see if they had any gaps in care, what those gaps in care are, so that right then we know somebody didn't have their pap smear, didn't get a flu shot, we can take care of it right there. We're able to see their health risk assessment results. If they've had labs, one of the biggest wastes in healthcare is people repeating tests because they can't see the results. So we also have the lab results right within that system. We can see who ordered them, and we can see the results. So again, we're not repeating a test that was just done by somebody else, and then if we also repeat a test, we can get the comparison. We go to questions now, or?
Okay. I'd like to sort of remind you that your 15 minutes is sort of passed. We'll give you a little bit more time to summarize or make the key points that you want to make.
Okay. And we thank you for giving us a few minutes. Sometimes when Ed gets up here, his passion has a tendency to run a little further, and then I have to follow him with numbers. That's a challenge. I think what's really important, Ed has gone over what we think our value is and how we really approach things a little different than others. The performance guarantees. I think that there needs to be some assurances that we can back up and do what we say. So if you really look at page 4, that's around the performance guarantees. These are all linked to that one number that I had referenced, which was called the management fee, that $88,000 that was reported in there. That if you look at, we have proposed 2 components of performance guarantees. One is around that budget that we mutually agree upon and say this is what it's going to cost to run that facility. Then we're held accountable to operating that budget. And if you look at the guarantee, we put 100% of that dollars at risk. And with the payout that, if we go beyond 10%, we owe all of it. If it's, within the 10% or above the 10% to 50%. And a little cushion around the 5. The other, in addition, on top of that is, so we've actually put the management fee at risk twice here in this proposal. The other is around patient satisfaction. That at the end of the day, if we can't get people into the clinic and they're not pleased with the services, you're never going to be successful, so we need to measure that. And what we will do is collectively develop the patient satisfaction survey that we need. We will survey and report that on a regular basis. It's usually monthly. And if we have satisfaction ranges that drop below the 80%, then we owe you 100% of the management fee back.
Okay. We want to give our members an opportunity to ask you some questions if they'd like. So who has some clarification or questions they'd like to ask this group? Ms. Stevenson does.
In your packet, one of the things it says in here is communications include pre-launch, grand opening, and ongoing communications to maintain awareness. How often and what media will you use to do these communications? Are you saying annually we'll send you?
That really really gets into the communication plan and strategy, and what we have are already documents that we know have been successful with the opening of other clinics, so we will give you the opportunity to review that. You have also the opportunity to select, mutually we'll work together on what may be appropriate. Then you turn that into the campaign, and because it's a campaign, it's not just once a quarter, it's probably on an ongoing basis, because the campaign is more than just awareness of the facility and the clinic. It's also around other programs that we want the clinic to be providing that goes beyond just seeing a patient. And that gets into maybe some of the wellness presentations and, kind of heading down the educational side of it too. And in that budget, we do a placeholder for you. The first year is usually around $10,000 is what we bake in, and then assuming that you have gone through all of the educational, which is really the startup of the awareness, then I think it dwindles down years 2, 3, and 4 to maybe around a $5,000 placeholder in the budget for communication marketing.
One of the things to share on that question real quickly is that we have 64 programs already developed, because one of the things we expect is the staff to also, the worst thing we can do is expect clinicians to sit in an office the whole time and people come to them. So one of the things we try and schedule in there is outreaches where we can do lunch and learns, or even set up if there's a common area in different sites where you can do blood pressure checks, you can do body composition checks, because again, the more visible they become, the practitioners become part of your culture. And so all those programs are also within that communications and how we do those outreaches and how we get people engaged versus just sitting back and saying, hey, come see us, we're here.
Yeah, it's really what we refer to as our toolkit that we give clinicians, and as Ed said, it's well over 60 lifestyle management programs that you can select based off of the population that they're serving. If you have a high propensity for obesity, we do that. If you have a high propensity for cardiovascular, we'll do that. If it's for diabetes, we'll do that. Or you can roll it up and call it metabolic syndrome, and we can do that. So they have a real toolkit that they can pull from, so they're not having to reinvent wheels. And this has gone through Cigna's clinical credentialing, so that we have all the confidence in the world with the integrity of the information that our clinicians are delivering.
Thank you. Also in your book, you mentioned one of your clients, the Palm Beach County Sheriff's Office, and it did hours of operation 3 days early, 2 days late. Is there impact fee that's associated with that if you have early hours versus late hours and all of that?
No, there is no impact, because remember, this is your budget, that we will agree on it, and hours of operation are one. The only difficulty with hours of operations is hiring the appropriate people that's willing to do kind of split shift work. And doing split shift work, you might have to pay marginally more, but that would be the only increase in cost. And those are things that we would work with you to identify up front before we get into the clinical recruiting side of it.
Anyone have any other questions? Ms. Barnes?
Would you talk about your plan and capability for scheduling appointments, setting limits within those appointments for employees so they can't schedule multiple appointments and different things like that?
Well, one of the questions that when we were out here the first time was the ability, from my understanding, had been an issue is blocking people from scheduling in multiple sites at different times and taking up appointments. One of the things we talked about last time is that we will have to have an administrative person responsible for a couple things. One is one phone number, so people can call one phone number to schedule, so they're not looking at each site to trying to find that phone number and connect. Number two is having that view to look and to make sure that people don't do those multiple appointments. But there's also another piece that's very important. One of the things that will also be attached to the electronic health record is a patient portal. But it's also when people are scheduling appointments, because there's a lot of times as a clinician, I know that person's going to need more time. Sometimes it can be condition related. Sometimes it can be, I know that patient really well, and I know there is no way in this world that that person can, they've got so many issues that they're going to need more time. So one of the things that also happens when we look at scheduling is we also are always reviewing, looking, knowing our patients to make sure we have the appropriate time scheduled. Because if you don't, then all of a sudden now you have people needing more time, not having enough, et cetera. So it will be something that we'll be oversighting. The other thing is that one of the things with Cigna Onsite Health that I have to share is that we have been very nimble in the way that the recognition that what you do today in 3 years may not work in 4 years. And so it's constantly working with you as partners. We don't want to be a vendor. We want to be a partner with Rutherford County, taking a look, and if things need to be adjusted, again, having that nimbleness to be adjusting to make sure that we're always providing the best customer service. So I hope that answered that. I'm sorry, say it again, please. Yes, we'll have online scheduling for you.
Ms. Hickerson, did you have a question? Ms. Regina can go and I'll... Oh, okay, I didn't see her, Ms. Regina.
Currently, we have programs that are code for our clinic, like weight, stop smoking, those type of things. What type of programs would you have available for employees, and how often would they be running per month? Is it something that you have on a continuous basis?
Okay. So there's a couple pieces of that. One is the programs that you have currently purchased, we want to make sure that we're able to refer people into. When we look at specific sites and identifying needs, so for example, let's say we find a significant patient population in a site who weight is an issue. Then what it's going to be is understanding that need, and again, not having been in your sites at this point, working with you guys to understand that need so we can schedule appropriate programs. Because one of the things that's great is that, again, with all these seminars and educational pieces that are built up, it's being able to deliver those. One of the things that we find very effective also, though, is there's a lot of people who you can get them in different programs, but the group setting doesn't work for them. I mean, many people, they're very uncomfortable with that. So it's also being able to work with the individuals who have those conditions. So, you know, I really can't say how often or what it would look like because I have complete ignorance on that of knowing what exactly your programs, how they're set up currently. But again, that's where that partnership comes in to understand the need and then to work accordingly.
Well, and in addition to that, what we will do is, clearly what Ed was looking at is you've already have purchased programs, so we need to be cognizant of those programs so that we can appropriately refer. We also have the ability to augment those programs, to supplement it, and that's part of these 60-plus lifestyle management programs. As far as frequency, that's something to where we would sit down, mutually agree on setting expectation for our clinicians, then those become part of their performance objectives. So if what we have agreed in one site is that we want one lifestyle management program, you know, per month or 2 per month, then those are the agreements we come to, and we set the expectations with the clinicians that they're going to be held accountable to that type of delivery.
Ms. Hickerson.
Okay, through some cheat notes that we were provided, just a little background on the company and how long you've done on-site medical. It says here that the on-site, we know Cigna's been around for a while, but you all have only been doing the on-site for 4 years, and right now you're just having 80 clinics. Now, is that 80 clinics or is that 80 different Rutherford counties?
I came from the medical group. I was the chief operating officer for Cigna's big medical group in the Southwest, one of the largest on the West Coast. So what we did was we took those resources and capabilities to also provide some similar services on site. We've been doing it for about 3 years. Today, when that 80-ish number that you had referenced and that we are referring to clinics, those are combinations. Those can be clinical delivery, meaning there is a practitioner that's actually touching a patient and delivering care, up to a coaching clinic, which means we have a master's level and or RN providing just much more of the wellness function. When you break that down a little further, you're probably looking at maybe 21 of those being clinical, you know, by the end of the year. The rest of those are associated coaching clinics. And then we are also branching out and doing on-site pharmacy.
And do you have any clinics, on-site clinics in Tennessee with us now?
We do not in Tennessee.
Okay.
We have a Cigna, actually we're up in Chattanooga, where we have a big call center. Cigna does have an on-site clinic that we are running there.
Okay.
Practitioner mid-level clinic.
Okay, thank you. If there are no other pressing questions, I think we will thank them for their presentation, and we will.
Thank you for your time.
Thank you very much. Thank you. Okay, as soon as we can change out this group from another group, then we'll bring in the Take Care. Okay, with the Care Here group, then they can assemble themselves, not Care Here, Take Care. Sorry, Freudian slip there. Whoever's in charge of this group and this team can come forward and introduce the rest of us, and you can proceed and tell us how you wish to make your presentation. We'll remind you we're trying to hold this to 15 minutes plus questions and answers, so you can use your time wisely.
Okay, thank you. I'm Trent Riley with Take Care Health Systems. I lead the operations team for all of the Take Care Employer Solutions group. I'd like to thank Mayor Burgess, the Insurance Committee, and Melissa for the opportunity to discuss our presentation today to serve Rutherford County. Just my team from an introduction perspective, we have Joe Rosato, the sales director. We have Adam Terry, our pricing lead. We have Katrina Lubers, which is in charge of our health and wellness area. And we have Vincent Bradley, which is our divisional vice president and leads the overall Employer Solutions division. Just a little bit about Take Care Health Systems. We are a dedicated provider of on-site health care across the country. That's all we do. We're not conflicted by any other service. We have a 40-plus year history of doing that. We have 370 locations across the country where we serve employers today. Our headquarters is in Middle Tennessee. We're in Franklin, Tennessee, about 35 miles up the road. We have a 50,000 square foot facility there with 200 employees. Anybody that knows anything about me, I'm excited about the work that we do and what we bring to employers, and I happen to be a Rutherford County resident. So any time you have an opportunity to give back to a community that gives to you, it's an exciting opportunity, certainly for me. I think there's some things between Take Care and Rutherford County that we have in common related to a goal and objective perspective, and that's high quality service to the populations that we serve. And I think you'll see that from Take Care Health Systems as we discuss things today, that we're always striving to serve our population with quality programs, whether that be from a clinical excellence perspective, whether that be a patient satisfaction perspective, or customer satisfaction perspective. Certainly, as a utilizer of county services, I feel that from Rutherford County every single day. Just the common services that I see every day and I utilize, and then certainly from a school system perspective, I'm a heavy utilizer. I have 5 children. 4 of those children are in the school system now. And certainly from a measurement perspective, my children are getting a high quality education. Certainly by the TCAP scores that we've seen, and my junior in high school just took the ACT and certainly bragging about the score he received. So those type of measurements is what Take Care strives to lay out, so we make sure that we're providing our populations, and certainly Rutherford County, with the high quality services that they deserve. One thing that I want to state is our approach to this model is different than the approach that you're receiving today. We want to hire a dedicated team that's focused solely on Rutherford County and their patients. Okay? I think that's a very important differentiator. When I talked to Mary in the proposal, she talked about her men. And that's what our physicians and providers do. They're their patients. They want to serve them. They want to provide a high quality care for them. And I think that's very important and a differentiator for us. With that, I think it's important for you to hear from the top of our organization what we're committed to do to serve Rutherford County. So I'd like to invite Vincent Bradley up, our Divisional Vice President, just to talk a little bit more about our services and what we're going to provide.
Great. Thank you, Trent. Mr. Mayor, committee members, and Ms. Stinson, we thank you for the opportunity and privilege to present to you today. What I'd like to do is expound a little bit on what Trent stated and really cover 4 areas that we believe differentiate Take Care in regards to providing and hopefully earning the opportunity to serve your employees and their families. Trent mentioned experience. Take Care has been doing this for well over 40 years of providing worksite health services. And he mentioned the nearly 400 locations, and we serve 180 clients across 45 states. And among those nearly 180 clients, 2 of them I want to mention. While we serve multiple government agencies, there's 2 counties that are very similar in regards to with Rutherford, Maricopa County in Arizona, as well as El Paso County in Colorado. Trent mentioned around around our focus on quality, but in addition to that, along with quality, we've been able to demonstrate through proven results that we're not a newcomer to this business. And one of the things we take pride in, even though we're the largest provider of these services in the country, we pride ourselves on being able to tailor and have a flexible approach to serve you and your employees and their families. If you look across all of our locations, not one of them, no two are exactly the same. While we certainly try to leverage our scale and the experience that we have, every one of our sites, every one of our health centers is unique to that client because you have unique needs and unique services that we need to be able to provide. And that's certainly no different. The second area, in addition to experience, that we believe we have differentiation is around clinical quality. It's one of our building blocks in addition to service and everything that we do. We've built an infrastructure right here in Tennessee, along across the country, a separate department just focused on clinical quality. And in addition to the sort of having people in a department to support the local sites and to support the 5 locations that we hope to earn the opportunity to serve with you, is putting tools around that, around a clinical excellence scorecard, a regional medical director that's there on a regular basis, and other tools around auditing and accreditation through third parties, et cetera. And when we look at quality, we're not just looking at quality within treating a patient in the 4 walls of the exam room, but also how good of a job are we doing around continuity of care and collaborating and certainly making sure that community providers are brought into the loop and providing the great care that you deserve and expect. The third area of differentiation for us is around service. And we call it around customer satisfaction squared, because we really essentially serve 2 clients. First and foremost are our patients, your employees and their families. And secondly is around you as our client of North Rutherford County. And we believe in this so much that we've invested in a third party so that it's not just me or my team that's measuring that we have an independent organization measure that. So not only can we drive improvement in a very objective and independent way, but also becomes a source that I'll talk about in a moment in regards to performance guarantees and sort of, I suppose, putting our money where our mouth is. The fourth area of differentiation for us is commitment. While certainly we have an entire infrastructure and focus on service and quality and people that do that, we also believe it's important to put a financial commitment around that in the form of performance guarantees that even though it was requested in the RFP response, and I'll talk about that in a moment, we do this with many of our clients and feel it's a very important part of what we do. And so with us, we're prepared to put 100% of our management fee at risk in the form of performance guarantees in 4 areas that are consistent with where I think you all are driving for excellence. One, of course, is the experience. And when I talk about the experience, I mean the patient experience and what they experience every day within the health centers, as well as the client satisfaction as well, that being a component. Secondly, from implementation, you have a 9/1 start date, and I'm committing to you today that we can meet that timeline, we can meet it on budget, and we also put money at risk in order to make that happen. And thirdly is around some of the administrative and financial areas that are critical for our success, not only from meeting, and maintaining and managing through the budget, but also through the other parts of our infrastructure to ensure that we're delivering the care and service that you expect. And then lastly, and certainly not least, however, is around that medical and the clinical outcomes piece. While certainly a lot of those were outlined in the RFP, we're certainly happy to talk with you around how we measure that with other clients and put money at risk in order to demonstrate that commitment. So again, experience, clinical quality, service, and commitment. And as you may know from the RFP response, Take Care Health Systems is a wholly owned subsidiary, but separate, but a wholly owned subsidiary of Walgreens Co., and which already serves Rutherford County with 9 Walgreens stores and 2 retail nurse practitioner clinics. Well, that's clearly, I know, out of scope of the RFP response and what you're looking to today. If in the future, if we earn the opportunity and that makes sense for you and adds value for you to explore future integration opportunities, we'd love to have that conversation with you. The RFP was a very detailed one. I want to make sure that you hear from myself that we are committed and can deliver on all the services that are listed in the RFP, and our proposal reflects that. And I've mentioned already about the opening the facility on budget and on time. Trent mentioned about our focus on care. This is what we do. We're not a payer. We're not an insurer. We're a provider of services across the country. And we believe that level of independence is very important for us and for the rest of our clients. And in closing, before we open it up for questions, I hope, instead of providing you with the detailed presentation, we knew you had a number of responses and a lot of meetings that we've already had with you, and we really just wanted to speak to you just verbally and just extend to you what we hope to earn the opportunity and the privilege to serve Rutherford County. Thank you.
Okay, so is this your initial presentation, from your team? Okay, so now we would give our Insurance Committee members an opportunity to ask them some more questions, clarification.
Just one point I would ask for clarification on. I had provided with them a comparison sheet that talked about years of service and things of that nature, and I had indicated to them that you had over 20 years of service, and that came from your RFP. I know that there was CHD and Meridian Company originated in '68, and then they, in the late '80s, they opened up their first primary care. So your true experience with the primary care is little over 20 years. Is that correct? Is that based on your RFP, the first clinic opened? Maybe from a wellness and health management, it started 40 years ago, but the true clinic opened in the late 80s from the way I read your RFP.
Yeah, just from a clarification perspective, our first contract we still have, it's with Random House Books in New York City, and it is acute care. It's not primary care, but it's acute care. So in the RFP, from the way that we, we're a company of mergers and acquisitions. I've been with Take Care for 21 years. So I've been through a lot of those mergers and acquisitions, but we did do our first primary care facility, what we call true primary care, 20 years ago.
Okay.
Just for clarification.
And would you maybe review for us some of your other clients that you might even have here in Tennessee, governments or businesses?
Sure. I can speak about a couple. Just like probably with Rutherford County, obviously this is a public institution naturally, so it's easier to talk about Rutherford County. We have a number of private institutions that do not allow us to publicly state their name. However, some of them that are in the public record is probably, if that's okay, Mr. Mayor, to articulate it from that perspective. There certainly has been press with Disney World, and we operate a very large primary care and pharmacy at Disney World in Orlando. Intel Corporation, we have 14 locations with them. And we've opened, we have primary care among acute, episodic, and wellness and other services for them. I'm trying to remember now in regards to some of our recent press releases to make sure I speak appropriately on the record. Toyota Motor Manufacturing is a very large client of ours, and that's also in the public record, and we provide a myriad of services for them, ranging from occupational health through primary care and pharmacy services.
From a local perspective, Mayor, I think was one of your questions, who we provide services for. So Bridgestone Firestone, we provide services for. Vought, Ford Visteon, we provide services for. And then Cummins Engine, they have a facility here in downtown, and we also provide services in their Cookeville facility and across the country with them.
And let me ask a couple of more questions. You mentioned the performance guarantees, and you would put your, quote, management fee at risk. Have you already shared that with our subcommittee on how that might even work? I don't care to know about the details, but just a little bit more philosophy on that. And secondly, you mentioned that you are a wholly owned subsidiary of some portion of Walgreens, and we know they have some clinics. Is there any potential that would be there for any linkage between what we would be doing and Walgreens?
So as it relates to performance guarantees, so we have put, I'll leave it to the feasibility team to discuss whether or not that's been shared in regards to putting out 100% of our management fee at risk. I'm not sure if that's been shared to date, but I wanted to make sure that I went on record to tell you that if that hadn't been, that's a commitment that we're going to make. As it relates to how that's measured, typically with our prospective clients, they ask for, like you have in your RFP process, a number of areas that we would be willing to put at risk. And then what we'd like to do is also then sit down with you and say, what are the areas in regards to your strategic vision that mean the most, so we can align with that through a process that's very iterative and very consultative, certainly understanding that you're our client, but looking at, and what a lot of our clients have done in the past, have asked me and Trent and others, giving them examples of what we've put at risk. Not necessarily the contractual details of that, but what are the categories and so forth around those areas that I discussed. It's very common for performance guarantees to have the patient satisfaction scores be measured and be part of it. Certainly, depending upon the scope of service, Within primary care, some of the clinical outcomes of chronic disease and other attributes would also be categories. But we typically, in this stage of the process, talk about that in regards to, I won't say general terms, but from a category standpoint, and then sit down with you once hopefully we are selected to give that more granular level of detail.
Okay. And then what about Walgreens?
So Walgreens, we are a wholly owned subsidiary of Walgreens. As it relates to integration or collaboration with the consumer clinics and the pharmacies, certainly we would love to have that conversation and could certainly explore those. But we wanted to make sure that that wasn't what we were trying to present today. We really wanted to focus on what is most important to you, though certainly we would welcome that opportunity.
And if I recall, the access to use those retail clinics, it is an additional cost above the cost that we have been provided thus far. So the information I shared with you earlier does not reflect those retail utilization costs.
Right, the retail clinics, the retail nurse practitioner clinics, so there's 2 in Rutherford County, would be an additional charge, fee-for-service type situation. But certainly from an access perspective, we could open up that access from a safe ER, safe urgent care type situation to help the county. So we could coordinate that and make sure that was well coordinated to work well.
Other questions from any of you members of the committee? Ms. Grace.
What is your ratio between physicians and nurse practitioners and medical assistants in your clinics?
Are you referring to our proposal for Rutherford County or just globally?
Rutherford County.
Rutherford County. So I'm going to let Trent answer that question.
From a nurse practitioner physician perspective, it's 3.5 to 1. We have a dedicated full-time physician here, but then the nurse practitioners collaborating with the physician. As it relates to the MAs, it's a 1-to-1 ratio associated with that in the proposal.
And one thing I want to emphasize, Trent mentioned it, but I want to, if you don't mind me remaking the point, is that all of them are Take Care colleagues. So they are our employees that are dedicated to Rutherford County to serve you. So we're not sort of bringing in, bringing out, trying to refer, trying to bring in independent contractors. They are our employees that are salaried by us, that have our benefits, et cetera, and therefore they're leveraging all of those things I talked about as it relates to quality programs, et cetera, that they're required to certainly be adherent to, as well as to drive on behalf of the Rutherford County Health Centers. Thank you.
Okay. I don't see any. Yes, Mrs. Nolan has a question.
If you would go over the appointment structure, the appointments, how you structure the appointments, that they're not exactly 15-minute intervals.
Sure. Yeah, okay, I got it. So our appointment structure is, as you know, in the finals meeting we discussed, we have an online scheduling tool. That online scheduling tool is somewhat intuitive, okay? So it asks specific questions because not every appointment is a 15-minute appointment. It just doesn't work that way with primary care and acute episodic care. So it intuitively brings them to a point where we know a little bit more to say, a physical is not going to happen in 15 minutes. It may take 30 minutes. It may take 45 minutes. So that's the way we block our schedules. That's the way our tools work. It's just not, we think that every 15 minutes appointment is going to happen. What that happens in models like that is you get dissatisfaction from your patients because they walk in, they see the provider, it's not a 15-minute visit, and then they have to schedule another visit. So that's how we handle that.
So to further that point, so we provide that level of flexibility so that depending upon, I'll use a medical term, but chief complaint, that will drive whether or not we assess that's a 15-minute or a 30-minute or potentially even an hour appointment. And really we drive our scheduling as well as, in regards to driving productivity, if you will, with our providers to ensure that they have the appropriate and adequate time with patients based on what their needs are. And that can be done both online, calling in, online appointment scheduling, calling in, as well as doing same-day walk-ins. Obviously, that sometimes impacts service from a wait perspective, depending upon those patients that have a schedule. But certainly, we've have great experience and great success in trying to build an efficient but also flexible enough system to be able to accommodate as many patients as possible. Thank you.
And Ms. Hickerson?
Yes, along the lines with the appointment scheduling, just from previous being in the subcommittee, and how the employees and time and stuff works, is it my understanding that if it was simply that I just needed a lab draw for my annual blood work, that the medical assistant could do that, and that would be a 5-minute appointment, and I would be in and out and see her or him, and not even mess with seeing the doctor or the nurse practitioner. So that's how we can, is that my understanding, how we can do that?
That's absolutely correct.
Juggle the appointments better, that you have the ability of coming in, because I know we have some that you have to take up a 15 or 20-minute appointment, and all you need is a blood draw.
It's a great question, a great point. So to sort of distinguish, Mary, between the question we just answered, we're really focusing on the provider appointments. Clearly, we want to make sure that we're serving your employees and their families in an efficient way as possible. So therefore, if it doesn't require a provider, we wouldn't take up that scheduling. That would be a separate approach and separate, I guess, workflow to make sure it's efficient and effective for that employee or their family member. So absolutely, yes.
Mr. Hester?
Yes, on the projected startup cost of approximately $232,000. We understand that's a true startup cost. This now is more of a transition. Could you expand on this a little bit and how those could change based upon being a transition rather than a true start?
So I'm going to invite Adam Terry up with us. He's our pricing lead, and certainly he can help us to answer this question, okay? I think part of the things when we go into an implementation, which even though this is a transition, this is certainly an implementation for us. And so we're going to sit down and we're very collaborative with our partners. So we consider you our partner. So as we assess some of the things, there could be reduction in cost because, you know, the medical equipment and the things that are on site there, we can bring over. So there's some of those things and services that potentially would reduce that cost. But I think one of the things that you're going to see with us is that we're not going to go higher than that cost unless it's a change in scope. We sit down with the team and we identify that. Adam, did I miss anything with that?
Absolutely. We do it as a cost plus budget. Our aim, we try to be very conservative in our projections to give you, I won't say worst case scenario, but for what it was detailed out in the RFP, we want to be accurate, give you a picture of what it could potentially be, but we're not going to set and say you're going to pay us this amount of money. We're going to work with you in establishing this is what we need to do. This is the startup time that's necessary. As Trent has noted, the equipment. So absolutely, we're going to work collaboratively with you to make sure we stay well within that. Definitely, if not.
And just to add a little bit more color to that question and the comments made, when you look at the detail of that 187,000, the 61,000 as it relates to startup salaries, wages. That's really about onboarding our new colleagues, the new physician and nurse practitioners for the training to get them ready to serve you before when we open our doors. So that's really what that's in relationship to. So it's not, you know, corporate folks. It's really the training for Rutherford County dedicated colleagues that'll serve you. So that a lot of the majority of these costs are associated with bringing those new colleagues on board. We've assumed, you know, we tried to eliminate, as I look here, from the furnishings, equipment, and supplies, making the assumption that what you currently have is adequate, appropriate, et cetera, so that we're not. Obviously, we're investing your dollars and using your dollars very wisely. So there's none of that is in there. Thank you.
Okay, are there any more questions?
I have just one more comment, Trent, if you could just clarify this. You spoke to the clinical staff that would be allocated to the clinics, but also I had shared with them earlier that the overall FTEs are about at 11. There is also a full-time health educator built into your pricing, and there's also 2 operations staff built into the pricing as well. Is that correct?
That is correct.
Okay.
Okay. If there are no other questions in, we appreciate your presentation and thank you very much.
Thank you.
Okay, we've had these presentations and this discussion, and Mrs. Stinson, are you going to continue this discussion, or you've already covered this sheet of paper here. So what are your wishes and how do we continue this? Do you have additional questions? Are you ready to make any suggestions? What's the thought of the committee?
There's one other piece of information that we didn't ask that I wanted to share. If you look at the satisfaction survey, how we obtain refills is something that we hear from our employees. And in both scenarios, they both have an online refill process where you can communicate, make a request for the online refill, and they will determine whether or not they can go ahead and refill that through the online request or if it requires an appointment. But that is one thing that both companies do offer to our employees. I had indicated earlier that I would be happy to go over kind of the outcome of the subcommittee meeting if anyone has an interest in that. I readily admit that it was a very intense conversation. It was a very long conversation. There was a lot of information to go over, and a lot of time was spent in discussion of what have our clinics been and what do we really want those clinics to reflect in the future for our employees. And one of the tools that we used was a satisfaction survey that I looked at, or that I've mentioned a couple of times. And when we looked at those, kind of the resounding themes was the availability of appointments, which we have had an impact to that by how many clinic hours that we've allowed to be scheduled through Care Here, and the number of clinic locations. So we have bared some responsibility in that. The process of attaining an appointment, the dedication of the staff was something that we were looking at, the availability of the medications and the ease of obtaining the refills. And we also looked at, the subcommittee discussed the experience level of the vendors, the clients they currently have inside of their portfolio, and the availability of the other programs, such as the retail utilization for Take Care would be one example that we just recently discussed. Cigna has demonstrated themselves to us over, at least I know since I came in June, they've been a very good partner to me in the medical management of our claims and providing with information. And so that was a discussion that was favorable for Cigna, is that they are already entrenched in the county, they're dedicated to the county, they've demonstrated that to us. And because of that, we feel like that we would get great service from them simply because they already know us and they have a commitment to us. Some of the unfavorable or some of their less strong points was they haven't had a lot of experience in managing on-site compared to Take Care. They're roughly at, I had indicated 4, they're roughly like at 3 years and 10 months of that nature, so they're right on the tip of 4 years. And you know, that's not a very long time whenever you talk about management of people's welfare and how much opportunity have you had to learn and try different varieties of approaches. The other piece, which was probably the biggest piece that was discussion in regards to Cigna, was the unknown. There is, I believe as one subcommittee member had put it down as eggs in a basket mentality. And what is our concerns of having all of the eggs in the basket? They referenced the relationship with the prior medical administrator where there was that kind of a multitude of services and entrenchment with that particular medical administrator, and there was difficulty once that relationship terminated. And I think that past experience created concerns in revisiting that same type of approach. So that had a significant impact on the review of Cigna, along with the unknown cost. When they looked at Take Care, the feedback that was given was their portfolio of services that they provide, their ability to use our existing hours that we allow for clinics and to increase our utilization in those clinics by using the medical assistants to do lab draws, as Ms. Hickerson talked about earlier, and really doing a more personalized approach to scheduling, which will allow us to maintain our costs below our 2010 cost and increase our utilization. So that was a significant point for Take Care in the review that was repeated. The other thing was, I may have said this, was the number of years that they've had the experience in managing the clinics and our ability to look at some of the retail sites for future development in our portfolio. I talked earlier about, we want to make sure that we can retain staff should we ever change management companies. They have both agreed to allow us to brand them, whereas right now we carry the company name of the vendor for our clinics. We will most likely brand those clinics so that there is a continuous name associated with our clinics, and it's not associated with the vendor themselves. So it will give us, as we go and design these, it will give us more flexibility, more control over our clinics so that we can have greater ability to impact those clinics. Ultimately, and as I said, it was a long discussion and deliberation over all the information that was provided, but ultimately the subcommittee indicated back to me that their choice of the two vendors would be Take Care. They were more comfortable for multiple reasons making that decision to recommend Take Care over Cigna.
So were those your comments in summary, Ms. Stinson?
Yes, of the subcommittee, yes.
Okay, so we're ready for your discussion out there, your motion. I mean, we can have a motion to select one of these providers, or you could make a motion to that both of them are acceptable, and we would call the roll, and you could vote for the one that you think is best in your judgment. So give you a moment to think about that. Who wants to address this? Mr. Sandvig does, I believe.
I have a question.
I have a question, okay.
Are the staffing models they're proposing comparable?
I think it's difficult to say if they are comparable, and here's the reason why. These are dedicated full-time resources to the county, whereas currently we have some dedicated resources. We have 5 full-time employees, but the remaining are part-time or PRN employees. And I actually expected that question to be asked, and I pulled out the invoice that we received recently. And the way that we're currently billed is it will have the name of the provider and the number of hours of service. And there was a long list of names on that invoice. So I think that there is enough staffing to cover the existing hours is the best way to answer that. But you really can't do a comparison of apples to apples because it's 2 different staffing models.
But in Take Care and Cigna, from the best you can tell, fairly comparable?
Right. I think the difference is there's 2 individuals. It's a difference of 2. There's a recommendation of 9 employees with Cigna and 11 with Take Care. The difference is one operational, what I call an operational support person, and the other is the full-time health educator that we would have through the Take Care arrangement. And just so that if you're not familiar with health educators, we currently have Ms. Perrin, which is our wellness coordinator, and she facilitates the events in conjunction with Cigna and Care Here and other providers right now. That's some of the things that Ms. Harvey had referenced. We would still continue that process, but we would also have a full-time health educator that would enable us to do some of the things that we really don't have the ability to do right now. So as an example, as we stratify information and we say, wow, we're seeing a lot of folks from this particular school with this scenario, then we could have that health educator build something to go with approval into that school and do something specific inside of that particular school or that particular office that addresses that employee population. So I think it would give us a greater approach on wellness than what we have right now.
I always look at the numbers, as you all know. I have some concerns at a $5 difference in the per employee per month cost. Is what on your colored page, the bottom line, and I'd like to understand why you feel that is worth it.
I'm sorry,
on the
Take Care is $5 per enrollment.
Oh, I see.
Right, $32.61 versus $27.34.
Sure.
One of the things is that we talked about is that if you see the to be determined on Cigna, we don't have those prices, those costs included right now, because as Cigna being our medical provider, they're already included in that package. but should we ever have a different medical provider, those costs would be incurred to best estimate based on what we're paying for now, the $275 per person, the $140,000 would be additional. That's why you can't necessarily compare the 32% to the 5% savings, because some of the costs that are associated with Take Care that they're having to pay or they're having to bill for, Cigna's not having to bill for because we already have them as our provider. So
and the $275 that Ms. Stevenson's referencing, that is for the cardiac and diabetic program only. So when you talk about the actual per employee per month cost for a full-fledged wellness initiative, you could reasonably expect it to be upward of that number.
Okay. I feel better hearing that.
Okay.
Okay. Ms. Hickerson? What?
Ms. Nolan has.
Oh, was somebody over here wanting to say something? Ms. Nolan?
Follow-up. It's a follow-up for Jeff. With the Take Care, that also reflects, or just clarify on the startup cost.
The startup costs are not included in the annual cost.
No, I know. Oh, they're not?
They're not.
Okay, I'm with you then. Okay, never mind.
And part of the reason of not looking at it like that is that what we addressed earlier, which is you can expect that number to change once the audit comes through and they look at what our current resources are in the clinics.
Ms. Barnes?
If I remember correctly, both of these groups have one position and then the rest PAs, correct?
I can give you the breakout. I have that here. So for Cigna, the breakout is 1 medical doctor, 3 nurse practitioners, 4 medical assistants, and 1 operations staff. The Take Care proposal has 1 medical doctor, 3.5 nurse practitioners, 3.5 medical assistants, 1 health educator, and 2 operations staff.
Thank you. I think the thing that stands out to me for Take Care, and I wanted to ask you, there's probably no way to identify the number of appointments that were not scheduled with Care Here because they were not available to employees. I mean, I can only speak for myself personally. When I went online to try to make an appointment and everything was booked, and I said, oh, heck, I'll just try to get well on my own. So when they talk about this scheduling mechanism, that stands out to me because I think they're going to see, I hope to see many more people than they would typically.
Yeah, and I think that
with
some
the way
of
they're going to schedule.
Right, some of the, discussion in the subcommittee, and you all can say, whether you recall this or not, is the frequency that you would enter into a clinic and you would find both the physician and the MA not actively in treatment of someone. So through that, we recognize that whenever Take Care says you can have somebody come in and that MA can do a blood draw, then we know, just based on our own utilization of the clinics, that there really is an opportunity for that to occur because you don't readily find both the MA and the clinician busily working each time that you go in.
Okay. Ms. Hickerson, we're calling on you to see what you have to suggest.
Okay, with all of that being said, going down to talking about the operational person or persons, it was a big deal to me not to pay a doctor or the nurse practitioner $100, $200 an hour, I don't know what they make, to sit and make these phone calls or to check and make sure appointments are being met and everything. So that's where our operational person comes in. And right now with Care Here, we're calling a 1-800 number, and I honestly and truthfully have no idea where that person is at. When we get our number set up with either company, when we get our number set up and everything, we're calling one of the clinics that has access to see all of the appointments and everything of what's going on and who's where. So we will literally be talking to somebody with Rutherford County, not somebody that says, what county are you from or what group are you from? They're from Rutherford County and they know our group. And with that and all of the other discussion, yes, there is a $5 difference. There's also 16 years difference in how long they've been in caring for on-site clinics and people, and there's a difference from 180 clients to 20 clients, and outside of Cigna, just having the one in Chattanooga at their local office or whatever there, just for their people. You get what you pay for. So I was part of the committee, and after looking at all of it, we've been down the road of starting with a new company in this new, like Care Here. We were Care Here's second client. They started in Sumner County. We were their second client. So it just, I like both presentations, but I also like the fact that Take Care has been doing it a little longer. And they seem with the ability in the future of possibly going out to their clinic after hours at a Walgreens may be a big benefit to some of our employees, especially if we just keep right now the appointment times from 7 to 5 or 7 to 6 during the day, because, you know, my guys work 6:30 to 5. You know, and in the sheriff's department, they have split shifts and stuff. So it's just a benefit. So based on all of the discussion and everything that we have, I'd like to make a motion that we do forward Take Care with all the comments attached to it as to why the $5 is not a big deal based on the service that we're going to get and the experience we're going to get for the $5 difference.
So we have a motion. Ms. Hickerson, let me suggest maybe one thing. See if you would like to include this in your motion. You're making the motion then that we accept Take Care as our provider of on-site clinic services, and that you potentially would allow the freedom for our insurance staff to maybe make minor adjustments as they actually work out the official agreement with them.
Oh, absolutely, yes, sir.
Okay. Now, we have a motion. Now, let's see if we can get a second or not. Ms. Crace is seconding the motion. Now, discussion. Okay. Well, since you've only nominated and select one, I don't guess we'll have to do a roll call. We're going to do a voice vote. If there's no other discussion, all of you in favor of this, please say aye. Aye. Are there any opposed? Hearing no one opposed, I want the record to reflect that it was unanimous. Okay, thank you very much for this. It's been I guess I should really personally thank the subcommittee. They've spent a minimum of 3 full days on this, I would say, reviewing this with these people over an extended period of time. So it is a complex, difficult, but very, very important decision that you have made. All right, Mrs. Stinson, we will go to your discussion about the health insurance rates for 2012.
Let me uncover those documents that I buried through their presentation. Okay. If you refer to the premium needs sheet, it's the sheet that looks like this if you've laid it elsewhere. I want to open the discussion by reminding you of what we talked about in the last insurance meeting related to healthcare reform. Healthcare reform stipulates to us that each individual option is viewed as its own entity, and therefore, beginning in 2018, we have to have premium that matches the experience within each option. So beginning next year, we will still have 6 years to adjust our premiums the way that we need to be. We've offered insurance in the county for decades, so it won't be a simple project in adjusting those premiums. So when I looked at and did the premium projections for the upcoming year, as you will see, if healthcare reform was to take effect in 2012, in option 1, we would be required to take a 32.6% increase. In option 2, we would be required to take a 6.7% increase. And in option 3, we actually have current funding levels that support the claims experience. When we talk about, and as we talked about earlier, what our financials have been, inside of these premium rates is an 8% medical trend rate, which actually is less than what you see on a 10 to 12% that is generally used. But when we look at our own financial experience, we see that we're trending down, which means that we're having a great year from a medical claims experience. If we maintain the current premium rates and utilize the expectation that our medical trend will continue to be down next year over this year, as what we've seen the last 2 years, because for the last 2 years we see a downward trend or a very small increase in our trend, then we can reasonably assume that we will have enough premium contribution and reserves to fund our claims experience. So rather than take an increase this year in a year where we're not giving any type of increase from a payroll perspective, it's my recommendation that we do not take any increase on option 1, option 2, or option 3. And the only increases that we take on our retirees is on the post-65 category, where we are continuing to make those adjustments to get the spousal contribution rate up to the 50%. So if you will look at the second page, this will give you the 2012 plan year proposed renewal rates. Everything remains flat on this form, with the exception of if you'll go to the box in purple and look at the post-65 grandfathered category. You'll see that on the single rate, there's no increase being proposed because those rates are already accurately reflecting the 25% contribution by the employee. On the two-party, we take a slight increase, which equates to $3.78 a month. On the 1 over 1 under, we take a slight increase reflecting $2.79 a month. And on the family, we actually, that's a 4% drop in their current premium because they are actually at the correct adjusted rate of the 25% on the employee, 50% on the spousal portion. Now, what we need to do is, rather than having these discussions once a year, is you'll begin to see over the coming year me bringing forth various recommendations for the insurance committee to consider. It's not a one-time correction to prepare for 2018. We have a tendency to think that 6 years is a long ways away, but it's not. And especially when you're talking about changing the tide of behavior for the past few decades that we have. And the approach that we've taken in allowing an aggregated pot of premium to cover our claims experience is not an unusual approach that you would see in the management of a medical plan. But healthcare reform says we've got to start to do something different. So rather than make a knee-jerk attempt at starting that correction process, I would prefer to leave things as they are and then come up with a master plan that we all agree on to help correct the premium subsidization that we're seeing from one option to another, and start to change the way that we look at it from an aggregated basis to an actual plan option basis.
Okay, so let me let you clarify this. First of all, the simple question, is there any action that you need this group to take today, or are you just beginning to keep us informed? I know you said in the purple, that's the only group that you would recommend that we make these changes so that we can move them toward the proper percentage.
Yes, sir, that's correct. And we can also lump dental into this as well. Dental, the experience is showing that the premium levels are appropriate as they are, so dental rates aren't showing that they need an adjustment as well. So the only thing that would have an increase this year would be those post-65 grandfathered rates for the two-party and 1 over 1 under category.
And is it timely for us to go ahead and address those now, or do you want to wait till we have a bit more information before January the 1st?
No, sir, I think that we have adequate experience to go ahead and finalize these rates today.
Okay, so there are two rates that you're suggesting that need an increase, and that is under the post-65 grandfathered, the two-party rate would go up $3.78 per month, and the 1 over 1 under, or that is $2.79. Is that?
That's correct.
That's correct. So those
Right.
two rate increases is all that would be on the table. Is that correct?
Yes, sir, that's right.
Okay, do you understand that? I mean, Ms. Barton says she does. Okay. What's the wishes of the committee then? A motion to approve Ms. Hickerson to no recommended change to options 1, 2, or 3. The only changes we're proposing are for those two components there within the post-65 grandfathered group. Is that correct? Second, Mr. Jordan. Now discussion. Mrs. Harvey.
Remind me, when we set the premiums up for those that are grandfathered in to get that increase up, we were gonna phase it over so many years. How many years did we decide on, and what year is this?
We have one more year left. Right.
Okay, other questions? Mr. Jordan.
Well, I'm just going to say I think it's critical that we do this every year so we don't end up in the same position we were a couple of years ago by not looking at this. And $2.79 a month is a pretty doable thing for somebody out there instead of waiting 2 or 3 years and clobbering them with $15 or $20 at a time. So I'm very much in favor of this.
Mr. Sandvig.
Are we doing anything with the post-65 non-grandfathered?
No, the premium contribution rates are showing that they will be able to cover the experience. You said for the non-grandfathered, is that correct?
The non-grandfathered post-65.
Right, the non-grandfathered, if you look at the front sheet shows actives and retirees, and you will see on the necessary increase line that there is existing premium contributions that should cover expected claims experience.
In other words, their premiums are in excess of what they would actually have to be at this point.
I'm sorry.
The purple box is showing an increase for that.
The purple box. Post-65 none.
Yes, that would be the step increase. You're correct. I apologize. Yes, it is. Right. So it's just the step increases. That's correct.
Those retirees already know there's going to be an increase because we approved that.
Yes, uh-huh.
So they're already in place as they should be?
They are in the step process that Ms. Harvey talked about. So there is a step being applied on the post-65 as it should be.
So do we need to include that in our motion?
Yeah, what I would recommend the motion be is that we include the step increases where applicable on the post-65 categories.
Post-65
yes,
retirees. Okay. Grandfathered and both non-grandfathered.
Correct.
Okay, so we have both of those. Thank you, Mr. Sandvik. Is that okay with you, Mrs. Hickerson and Mr. Jordan? Any other discussion? All of you in favor of this, then please say aye. Aye. Any opposed? Thank you very much. Okay, we missed a meeting or two, and we're making up for it now, aren't we? All right, Mrs. Stinson, we're ready to talk about CCMSI?
Yes, Ms. Bowen is here from CCMSI, and she'll go over the renewal for those lines of business.
Thank you, Mayor Burgess and Ms. Stinson. We're going to switch gears this afternoon and talk a little bit about your property and casualty renewal. You should have the very colorful sheet that's several pages. I'm just going to go through this, and you can ask questions throughout if you'd like to. Your renewal comes up July the 1st. The very first page is your property coverage. You'll see that in the purple there, the insurance company this year will be Travelers. Your previous carrier was Allianz, and y'all had been with Allianz for approximately 7 to 8 years. Allianz decided to pull out of the public entity sector, and so actually Travelers went in and bought that book of business. So the terms and conditions are very favorable. Actually, you'll see a little bit better coverage with the Travelers form. I'm just going to kind of go across the page. If you'll look to the far right, you'll notice in the light blue, that's your rate. Your rate is the exact same as it was the previous year. You'll also see your expiring total insured value at $1,032,000,000. Your renewal is at $1,036,000,000, so slight increase there in the total insured values for your property, building and contents. In the red, you'll notice the premiums, so you'll see your expiring quote. In the light tan color, you'll see the expiring quote included an engineering fee. That was an inspection fee of $7,500. You'll notice in the renewal quote for travelers, there is no inspection fee. You'll also notice that it shows excluding terrorism. And I want to just drop down a little bit. If you'll go to the section where it says inland marine, all of the yellow, and then there's some pink in there. If you'll drop down to the very bottom, you'll notice terrorism. In your previous coverage with Allianz, your terrorism was built into the form at $2.5 million. Built into the form with the travelers is an automatic $10 million. If you wanted to include it at $100 million, which is your policy limits, with $100,000 retention, you would take that top premium to the far right in the red, the $361,802. Includes the full terrorism coverage at the $100 million. If you notice, I'll say in there excluding terrorism, because again, you did not purchase full limits last year. You had the limits of $2.5 million included. So I'm just trying to compare apples to apples from last year's expiring. So if you exclude the terrorism, there would be the reduction of $3,618, but you would still have $10 million worth of terrorism coverage. Versus the 2.5 from last year. There is a reduction in premium of approximately 2% in the property coverage. If you go to this next page, you'll see this is the crime insurance coverage. You will have the same carrier, which would be Great American Insurance Company. You'll notice the expiring limits, the expiring deductibles, and the premium. They are all flat. So there's no changes whatsoever in the crime coverage there. If you go over to the third page, this goes into your casualty renewal. It's your current carrier is ACE Insurance Company. Your casualty coverage covers the general liability, the law enforcement, public officials liability, employment practices, educators legal, auto liability, auto physical damage, garage keepers, sexual abuse, sexual harassment, and your nurse's professional liability. The limits and the retentions are exactly the same. Under the current casualty, you do not purchase terrorism coverage. That has always been quoted as an option. You'll see that in the light green. Your expiring premium, you'll see at the $643,688. It's a slight increase. That's due to exposure increase. At 3%. So you had a reduction on the property, even though you had an increase in property total insured values. And then you have an increase in the casualty side because of the exposure increase at 3%. If you go to the very last page, you'll kind of see some of the comparisons for exposure. The very top of the page, you see the contents and for the county, or the very first two for the property, and then you'll see the schools broken out. The expiring is in the purple. The renewal and difference is in the green. And then you'll see the miscellaneous equipment. The numbers are identical as far as exposure. On the contractor's equipment, the same, it holds true. The musical instruments for the schools are up slightly. And then you'll see your total insured values are up about $4,128,000 or 1%. If you go into the casualty side, you'll see the vehicles are slightly down. We've got to do some cross comparison there because they actually came back a lot substantially lower. The underwriter had some discussions about that. Ms. Stinson and I are continuing to work to make sure that we are covering all the vehicles that the county does maintain and own. Then you go into the general operating expenditures. Those are up around 5%. You look at, it's also based on population. And then we also this year had added in the fire department exposure, which is included where last year that coverage was not included. And then you'll see also the crime, public officials, educators, legal liability. There's a lot of different variations as far as rating bases there, but you'll see number of employees being up slightly, and then also the number of students increased about 4%. So the overall exposure increase is around 7%, and then the overall taking in your property, crime, and casualty is around a 2% increase. Are there any questions?
Ms. Bowman, that was a very, very concise and clear presentation. Now, Mr. Hester, you're used to looking at these things. Do you have any comments?
Yes, sir. It is. It is right at the very first under the inland marine. The earth movement is the 10 million limit. Yes, sir. And then floods right below that at the 10 million.
What he's saying is, what is earth movement? Is that earthquake? Or?
Yes, it would be. It would be earthquake.
Okay, Mr. Hester?
I only have one question. Yes, sir. And that's back on the first page where we were talking about the terrorism.
Yes, sir.
Quoted at 10 with the increase to 100. Would you explain to me exactly what that would cover?
Right.
And whether then what we need to consider if 3,600 is a good price to increase by that amount?
Yes, that would cover actually buildings that are owned by the county in the event of a terrorism act. Okay. The difference in premium, I will say this, if I went back and compared last year when Allianz had offered the full limits of $100 million, they were somewhere in the neighborhood of $18,000 to cover that additional exposure from the $2.5 million expiring up to the $100 million. But that would cover, like I said, any county-owned building. It would cover the contents. It is not necessarily going to, the definition of a terrorism act is not going to be as it would be under like a general liability. Under general liability, it has to be determined by the federal government as an act of terrorism. Under your own property, that's not going to be the same definition.
Okay, so this covers property only, not liability.
That is correct.
Okay, would you then go and speak a little further as to terrorism coverage for liability for the county?
Okay, be glad to. That would be on the third page over. At the very bottom in the yellow, you'll see the optional quote to the far right at $15,067. That would go back to cover any type of bodily injury or property damage not owned by the county. And that would, like I said, go under the definition of a terrorism act predicated by what the federal government stated, I think it was in 2001 or 2, the definition of a terrorism act.
What would the limit on that be?
That limit would be up to the policy limits at $5 million. Yes, sir.
Mr. Hall.
I just have one question on the value of the schools and buildings. The values went down. I was just curious, we didn't open a new school this year, right? And the values went down because the replacement value of them would be cheaper now because the economy is a little bit slower or something like that. Is that why they appraised lower?
Possibly. I think you guys have an independent that actually, a consultant that goes out and surveys the buildings and comes up with the statement of value, which is actually what we rate from.
Okay, so Mrs. Bowman and Mrs. Stinson, what course of action do we need here? We need to address all of these potential renewals, pages 1, 2, and 3. Yes. Is that where we are? And when's the effective date of these changes? When would they be?
July 1st.
This July 1st. And so on the first page, we have to determine if we want to, if we don't spend that $3,618, we're still going to have what? How many million you say in coverage? We still have $10 million, which is increased over what we currently had this previous year. So there's really not a lot of reason for us not to accept that reduction. Is that correct? The second page is exactly the same. And the third page, we have to determine if we want the optional terrorism coverage. Is that correct? Oh, and what, excuse me?
First page is our property.
First page is property.
The second is our crime.
The second page is crime, and third is casualty.
Yes, sir.
Okay, so does anyone understand this well enough to make a motion? You have a question, Mr. Hall?
Didn't we go through the definition of terrorism a couple years ago whenever we went through it? So if somebody was watching, I mean, if the government has to say it's terrorism, it's a lot. They're not going to say it's terrorism probably as often as they would, as we might think it might be terrorism, right? So that's the reason we didn't get it in years previous, correct? Okay, so I'll make sure.
I will say that most governmental entities that we currently insure, they will opt to include it in the property side, but typically exclude it in the general liability side because it's too broad.
Okay, who can be specific enough with a motion to address property, crime, and casualty insurance? Oh, you can't make a motion, Ms. Stevenson. You can ask a question.
I'm sorry, just for clarification. On the casualty side, do the same regulations apply to the acts of terrorism for that as well? The federal government has to, okay.
Mr. Sandvig.
I'd like to move that we approve these renewal quotes and forward them to the Budget Committee.
And Mr. Sandvig, on the casualty piece, does that include recommending the additional premium of $15,087 for terrorism?
No, it does not.
Not to include that one. Okay, is that clear? Mrs. Hickerson?
I'll second that motion.
You're going to second that motion. Now, any further discussion? All right, there being no more discussion, everyone in favor, please say aye. Aye. Anyone opposed? That is unanimous as well. We've had a very, very productive meeting, even though it's been a bit over 2 hours, so I appreciate your participation and your support and your interest and your good questions. Anyone else have any other business? If not, the Insurance and Benefits Committee meeting is adjourned. Thank you very much.